Good morning, honorable participants and speakers. Welcome to the AMSA International Webinar Series, Current Approach Towards COVID-19 of Day 2. We are having 2 lectures today and 1 question and answer sessions. If you are having any questions during the sessions, please ask them directly on Zoom chat room with the format. Good morning, honorable participants and speakers. Welcome to the AMSA International Webinar Series, Current Approach Towards COVID-19 of the. The questions that asked beside of the Zoom chat room will not be answered, and the questions will be read by chronological orders. Now we are going to start the sessions. Before we start the sessions, we will have words or two from our overall chairperson of AMSA International, Marjorie. To the Marjorie, the stage is yours.
Thank you so much, Jeremy. Good morning, everyone. Good morning, Dr. Angelina May Santos from the Department of Infectious Diseases, Philippine Children's Medical Center. Good morning, Prof. Roslina, my Deputy Dean of Undergraduate Studies, Senior Consultant Respiratory Physician from the Faculty of Medicine, the National University of Malaysia. Good morning, Prof.
Good morning.
It is really a great honor to see all of you participating on a Sunday morning. And I really congratulate my colleague, Jeremy, for pulling this out so successfully. Congratulations, Jeremy. Okay, so I will then start off with an address to all of you. Dear people of tomorrow, it is the 35th anniversary of AMSA International. I'm honored to be here with all of you. For decades, AMSA has committed to be an inspiring nest for knowledge cultivation, a prestigious home for momentous actions, and a strong network for abiding friendships. I myself have experienced them all, and this sweet nature has actually driven me to contribute and locally, nationally, and internationally. This year, it will be a different twist for academic as we will be setting it up as an official subsidiary of AMSA International. And thank you so much for being part of this journey. And this year, we'll be emphasizing on the knowledge vision of AMSA International. Just a recap, our visions are knowledge, action, and friendship. So this year, stay tuned and please continue to follow us on this knowledge vision through Jeremy's leadership under the subsidiary academic. So this subsidiary has been known to hold biannual competitions, but this year again twist with webinars and further other collaborations between subsidiaries, and I really hope to see all of you participate as well. So the members of AMSA International serve as the foundation and pillar of AMSA, all of you. We are very blessed for each of your presence. Your passion have inspired us to bring AMSA to greater heights. So therefore, I hereby AMSA International tenure 2020-2021 hope to see all of you in all of our future programs, and please spread words on all of our future programs as well. And together we overcome the pandemic together for a greater AMSA, and I hope that all of you will enjoy the session today. And I'm so sorry, it was actually me as the moderator, official moderator of this program, but due to another event and other circumstances, I cannot actually moderate this event. So Jeremy, on my behalf, have agreed to actually come forward and take up this responsibility today. Thank you so much, Jeremy. And again, my warmest regards to the speakers. Thank you for actually accepting and saying yes for attending and actually be part of this huge initiative of Jeremy. Thank you so much.
Thank you very much, Marjorie, and thank you very much for all the participants and speakers who have involved in this webinar. We have many participants from various countries, and I believe there is a huge benefits that we can take from these webinars. And I will start the first speech by Dr. Angeline May Santos. Dr. Santos is a pediatrician and pediatrician infection specialist who have practiced in the Philippines Children Medical Center in Manila, Philippines. And she graduated from the University of Santo Tomas for the MD, and she takes the pediatric infectious disease specialist. To the Dr. Angeline May Santos, the stage is yours.
Thank you. Hello?
Yes, I can hear you clearly. You may start now.
Okay. Good morning, everyone. So I would like to thank the AMSA for inviting me to lecture on this very timely topic. And so I'll be talking about the current prevention measure of COVID-19 and on updates on the vaccine progress. So I am Dr. Angeline May Santos, and I'm a pediatrician and a pediatric infectious disease specialist. And I'm part of the Infection Prevention and Control Committee of several hospitals here in the Philippines. So I hope to share some of the strategies that we've been doing in our setting for so far. And these are my objectives. So the novel beta coronavirus SARS-CoV-2 is believed to have emerged last year, 2019, in Wuhan, China, from bats. And Crossing the species barrier, it entered human beings with furtherance of infection through human-to-human transmission, and it has spread for over 188 countries and 25 territories around the globe. And on March 11, 2020, the World Health Organization announced COVID-19 as pandemic, and truth be told that neither vaccines nor direct acting antiviral drugs are available for the treatment or prevention of human and animal coronavirus infections. So it's very important that you understand what is infection prevention and control, and IPC has played an important and critical role in reducing transmission rates and impact of COVID-19 worldwide. So according to the World Health Organization, infection prevention and control is a scientific approach and practical solution designed to prevent harm caused by infection to patients and health workers. So this is grounded in infectious diseases, epidemiology, social science, and health system strengthening, and it includes various measures that prevent and contain the spread of infectious diseases. So let me just go back to the basics, and I think we have to know the basics of COVID-19. And what we are doing is we are basically breaking the chain for COVID-19 disease. So we know our infectious agent. We want to interrupt that transmission. So basically, COVID-19 has no definitive treatment yet. Our reservoir is the people and the environment, and our portal of exit is the respiratory droplets and the hands. Our mode of transmission is mostly contact, airborne, and droplet, and usually airborne comes into play on aerosol generating procedures, and our portal of entry from ourselves and to others is through our membranes. And unfortunately, we don't have vaccine or prophylactic therapy yet. So as we go on with our lecture, we'll tackle on how to break the chain for COVID-19 infection and how we can use the current infection prevention and control measures for COVID-19. So what are the goals in infection prevention and control? Why do we keep on discussing IPC, and why is it very important during this time? So the first goal of IPC during this time is to limit human-to-human transmission of an infectious agent. Number 2 is to reduce secondary transmissions, and we know that secondary infections contribute to the significant morbidity and mortality of patients. And number 3 is to prevent transmission through amplification and super spreading events. So it's very difficult to predict super spreading events. So fast public health action, especially IPC, can prevent and reduce the number and impact of super spreading events. Again, speed is very essential because as of today, there have been multiple reports of super spreading events which are associated with both explosive growth, early in outbreak, and sustained transmission in later stages. So standard precautions are used to prevent transmission of infectious agents through contact with non-intact skin, mucous membranes, or any body fluid, and they are a set of practices that are applied to the care of patients regardless of the state of infection in any place where health services are provided. So even before pandemic, standard precautions are one of the basics of infection prevention. So this usually includes hand hygiene, use of your PPE, respiratory hygiene, safe injection practices, sterilization, disinfection of medical devices, and environmental cleaning. So the transmission-based precautions are designed for patients documented or suspected to have colonization of infection with pathogens, for which additional precautions beyond standard precautions are recommended to prevent transmission. And there are 3 types of transmission routes, namely the contact precaution, droplet, and airborne precaution. So as long as there is no effective and safe vaccine to protect those at risk of severe COVID-19, standard precautions in addition to transmission-based precautions are the most effective interventions against COVID-19. So it's also critical to review the previous data from our previous coronavirus outbreaks that we had before, such as the SARS and the MERS outbreak. So during the start of pandemic and in the absence of initially of evidence for effectiveness of IPC, studies on SARS and MARS were reviewed, and multiple studies have shown that compliance with hand hygiene, medical mask or N95 respirators, the gloves, and the gowns were effective in preventing transmission of SARS-CoV-2. However, conversely, the inconsistent use of goggles, gowns, the gloves, and caps were associated with a higher risk for SARS infection, and overcrowding and suboptimal control of visitors were identified as risk factors for nosocomial spread of the virus, and the airflow and ventilation were identified as important factors influencing efficient spread of the virus in the hospitals. So there were several knowledge gaps that limit the identification of the best IPC measures to be implemented to contain the current spread of COVID-19. So the modes and duration of transmission of COVID-19 influences the selection of the most appropriate IPC measure and their optimal duration. It is important to also know the environmental stability of the virus and the effective methods to minimize the role of environment in transmission, the importance of specific or type of PPE or personal protective equipment to be used, implications of isolation, quarantine, and optimal healthcare pathways, and the best IPC measures to use in the community. So since we have identified some of these gaps, studies and evidences has now emerged on the characteristic of SARS-CoV-2 transmission. So what do we know so far? Evidence currently available indicates that COVID-19 may be transmitted from person to person by several routes, and it is understood that mainly its transmission is via respiratory droplets containing the SARS-CoV-2 virus. Transmission through aerosols occurs in closed spaces and during aerosol generating procedures, such as intubation done in healthcare settings. However, current data does not support long-range aerosol transmission of SARS-CoV-2, such as seen with measles or tuberculosis. Indirect transmission is possible, but role of other routes of transmission, such as fecal, oral, or bloodborne, has been very limited. So the incubation period ranges from 1 to 14 days with a median of 5 to 6 days. And current evidence has also showed that the infectious period begins at least 1 to 2 days before the onset of symptoms. And we know that some symptoms can often be mild and non-specific. And in these patients, they can be infectious for up to 10 days after onset of symptoms. And for patients with severe cases, it can be as long as 14 to 20 days. So the basic reproduction number is between 2 to 4, and we have an unclear data with regards to infectiousness by age. The proportion of asymptomatic cases were reported to be 30 to 40%, and definitely patients who are asymptomatic can transmit the virus. So risk factors for transmission most commonly include close contact, indoor settings, crowding, and travel. And the risk factors for the severity of the disease has been old age and the presence of underlying diseases such as hypertension, diabetes, or kidney diseases, etc. So I'd like to discuss IPC in two settings. So first, the infection prevention and control in healthcare settings. So these are the following, and one of the major changes in healthcare delivery during this pandemic is the use of telehealth medicine. So this is very important to reduce staff exposure to ill persons. We have to preserve personal protective equipment and to minimize the impact of patient surges on facilities. And by doing telehealth medicine, patients can be triaged and screened for COVID-19 symptoms and assess the patient's exposure to COVID-19. So the healthcare providers can also use this medium to conduct a remote evaluation of the patient's medical condition. So by doing this, we'll limit the exposure of healthcare workers in the hospital and also preserving the use of PPE. So screening everyone entering the healthcare facility for signs and symptoms of COVID-19 is also an important strategy in infection prevention and control in healthcare settings. So what we do here is we usually take their temperature, let them fill up a health declaration form so that appropriate precautions can be implemented by all staff and even the patients. So also, while screening is performed upon entry, it is important also to do daily assessments of all admitted patients so that appropriate transmission-based precautions can be done. So source control refers to use of your cloth face coverings or face masks to cover a person's mouth and nose to prevent spread of respiratory secretions when they're talking, sneezing, or coughing. So because of the potential for asymptomatic and pre-symptomatic transmission, source control measures are recommended for everyone in a healthcare facility, even if they do not have symptoms of COVID-19. And also, when possible, physical distancing or maintaining 6 feet between patients and coworkers should always be encouraged. So another strategy is to implement the universal use of personal protective equipment. So if SARS-CoV-2 infection is not suspected in a patient presenting for care, then of course, standard precautions and transmission-based precautions should always be implemented. So in addition to the use of universal personal protective equipment and source control in healthcare settings, targeted SARS-CoV-2 testing of patients without signs or symptoms of COVID-19 might be used to identify those with asymptomatic or pre-symptomatic infection and further reduce risk for exposure in some healthcare settings. This is especially important in patients with higher risk of exposure to COVID-19, such as those healthcare workers directly handling positive patients. And lastly, we optimize the use of engineering controls and indoor air quality, such as the use of your physical barriers, such as on this photo, or conducting outdoor assessment. So current IPC practices when caring for patients with suspected or confirmed SARS-CoV-2 infections include, again, the use of your personal protective equipment. And there are several recommendations for the use of PPE depending on the task that you are going to do. So in this slide is a sample poster we made for healthcare workers on the PPE requirement for based on their activity. And procedures that generate infectious aerosols such as intubation, bronchoscopy, CPR, suctioning, or sputum induction require an airborne and droplet-based precautions. And these procedures pose such risk and should be performed cautiously. So it is very important that during these procedures, a healthcare worker is wearing a level 4 PPE for protection. Usually that includes your respirator, a coverall, gowns, your eye protection such as goggles or face shield, and gloves. So for patients with COVID-19 or respiratory infections, it is very important to evaluate the need for hospitalizations because home care can be an option, especially if patients have mild symptoms. And if ever they will be admitted, they should be placed in a single person room with door closed and ideally should have a dedicated bathroom. In resource limited countries such as the Philippines, our hospitals have limited single room and negative pressure rooms are even limited. So we just cohort patients based on signs and symptoms with appropriate distance from each other. So limiting visitors to admitted patient is an important IPC measure to prevent transmission of the virus. So in our setting, in some of the hospitals I've worked with, we don't allow any visitors at all. So what we encourage is the use of alternative mechanisms such as video call applications on cell phones or even in tablets. So environmental infection control in patients with COVID-19 is usually the use of dedicated medical equipments for these patients. So the non-disposable medical equipment used for patient care should be cleaned and disinfected regularly. The use of disinfectant for routine cleaning and disinfection procedures should be regularly done, especially to frequently touch areas such as the doorknob or the bed railings, etc. And lastly, there should be regular reporting within and between the healthcare facilities and to public health authorities to implement mechanisms and policies that promote awareness on infection control, healthcare epidemiology, and occupational health, etc. So I'd like to add in my discussion these some of other non-pharmacological interventions. So they're usually public health measures that aim to prevent and or control SARS-CoV-2 transmission in the community. So as long as there is no effective and safe vaccine to protect those at risk of severe COVID-19, these are the most important interventions against COVID-19. However, one of the main challenges is achieving strong compliance with these interventions under any circumstances, let alone the given situation, is that there is no single approach that can be used in all settings and with all population groups. And throughout the world, these interventions have been employed by different countries and has reduced transmission of the SARS-CoV virus. There are three main categories. So the individual, usually what we do with ourselves, so hand hygiene, respiratory hygiene, and the use of face mask. Environmental usually involves cleaning and the ventilation of indoor spaces, and population related, usually promoting physical distancing, limiting and restricting movement, and the gathering of people. So avoiding physical contact and keeping a distance of 1 to 2 meters is considered to be a key preventive measure, and this has been promoted worldwide. And although there is scientific uncertainty regarding the distance that the SARS-CoV-2 can travel from an infectious individual, especially when that patient is breathing, talking, coughing, or sneezing, but definitely there is a correlation between proximity to an infectious person and the risk of virus transmission. So the risk of transmission is influenced by various factors that make each contact situation unique, such as the setting, whether it is indoor or an outdoor activity, or whether the infectious person is coughing or sneezing, the duration of exposure, and even environmental conditions such as the temperature, the humidity, and type of airflow. So in recent systemic review and meta-analysis, they found out that physical distancing of 1 meter or more was linked to five-fold reduction of the transmission risk, with twice the increased protective effect for every extra meter of distance added. So in addition to ensuring appropriate distance, physical barriers such as transparent screens can be used to decrease exposure to infectious droplets, especially in settings where there are multiple interactions and physical distancing is not possible. So the respiratory hygiene, usually the covering of the mouth and the nose when coughing and sneezing, with the aim of reducing person-to-person transmission through droplets, which we know is the most common mode of transmission for the coronavirus. And this has been widely used in all settings. So adherence to respiratory hygiene measures is strongly recommended, not just throughout the course of COVID-19 pandemic, but in all diseases transmissible by direct contact as a result of respiratory secretions. So recommending hand hygiene involves limited cost and no significant associated risk. And the literature reports that alcohol-based hand sanitizers offer limited added benefit over soap and water. But if if alcohol should be used, it should contain at least 60 to 85%. And although there are limited number of studies on the effect of hand hygiene on the prevention of COVID-19, a study from China reported that both suboptimal hand hygiene before and after contact with patients was linked to an increased risk of infection. So next, the use of face masks. So there are three common types of face masks that were commonly used during this pandemic. So we are familiar with the respirator or the filtering face piece, which is usually used as a protection from exposure to airborne contaminants. These are mainly used by healthcare workers, especially during aerosol generating procedures. The medical masks are also used by healthcare workers to prevent large respiratory droplets or splashes, and this can limit the transmission of an infective agent between hospital staff and patients. And lastly, the use of non-medical mask or community mask that usually includes various forms of self-made or commercial-made and face covers made of cloth, textile, or other materials. So they are not standardized and are not intended for use in healthcare settings or by healthcare professionals. So there is increasing evidence showing the effect of face masks in preventing SARS-CoV-2. So in a recent systemic review that the use showed that the use of face masks resulted to five-fold reduction of the transmission risk. So it's from 17.4% with no face mask to 3.1% with face masks. So in addition, face mask is thought to be linked to milder disease among infected individuals. So as to the community mask or self-made mask, actually this depends on the material and the construction of the mask, including the layering. However, no studies have directly evaluated the effect of non-medical mask on transmission. So your face shields and your goggles are used in healthcare in combination with face masks to prevent infectious droplets from reaching the eyes. It's also being used now in the community. So systemic review of evidence has shown that the eye protection is effective in preventing infection in an experimental study. Face shields can reduce the short-term exposure to large respiratory droplets by up to 96%, but are less effective against smaller droplets. However, due to still lack of evidence, the face shields or visors are only recommended in combination with a face mask. So we know that SARS-CoV can survive in the environment and it has been detected on frequently touched surfaces. So hence, regular environmental cleaning and disinfection is recommended to decrease the spread of the virus through this route. So we know that the SARS-CoV is an envelope virus and therefore it is sensitive to common detergents and disinfectants effective against the viruses. And the heating, ventilation, and air conditioning systems may play a complementary role in decreasing transmission in indoor spaces by increasing the rate of air exchange, decreasing recirculation of air, and the use of outdoor air. So this may be achieved by means of natural or mechanical ventilation, usually depending on the setting. So the isolation of symptomatic cases not requiring hospitalization has been done even before during the COVID-19 pandemic. And this is an effective measure for reducing transmission. And the objective of the measure is to reduce the chance that the possibly infectious individuals will have contact with others. So the early identification of cases to ensure rapid isolation and contact tracing is of paramount importance to prevent further spreading of the virus. So there've been a modeling study estimated that a high proportion of cases would need to self-isolate and a high proportion of their contacts would need to be successfully traced and quarantined to keep the effective reproduction number below 1 in the absence of other measures. So quarantining of contacts is recommended for healthy people who have had a high exposure to a confirmed COVID-19. And the objective is the early detection of cases and separation from other healthy people to avoid transmission if the disease develops. So even during asymptomatic, pre-symptomatic, or subclinical phases of the disease. So it has been shown that quarantining of people exposed to confirmed or suspected cases averted 44 to 81% of incident cases and 31 to 63% of deaths compared to no measures. So our review of modeling studies also suggested that when the models combined quarantine with other prevention and control measures, usually including the school closures, travel restrictions, and social distancing, they demonstrated a greater effect on the reduction of new cases, transmissions, and death than individual measures alone. So overall, quarantine may reduce the number of cases and delay the peak of transmission, and the effectiveness of this measure is enhanced when it is implemented in combination with other measures. So this the shielding of medically and socially vulnerable population is very important because they have an elevated risk of severe disease and death due to COVID-19. And most parts of the world in the Philippines, we have implemented the stay-at-home recommendations for risk groups and vulnerable populations. So it's also important to limit the size of gatherings, which can reduce the likelihood of SARS-CoV-2 spreading to large numbers of people. And this is especially important when there is community transmission, and it is regardless of the incidence levels. So the closure of non-essential businesses, especially the high-risk businesses, such as the bars, the nightclubs, the cinemas, the gyms, or even restaurants, showed reduction of SARS-CoV by 31% in 41 countries between the month of January and May 2020. And although the dynamic transmission of COVID-19 in children are said to be different. So children are more likely to have mild or asymptomatic infection, and it is unknown how infectious asymptomatic children are. However, we know that they are considered to be among the main drivers of infectious agent outbreaks. But so far, recent evidence are still unclear whether school closure during certain phases of COVID-19 are an effective way of reducing transmission. But international travel restrictions, this is usually done to reduce the risk of virus importation from countries with high transmission by implementing travel restrictions to or from an affected area. However, again, evidence available showing the impact of international travel restrictions and border closures are inconclusive. So evidence has just shown that border closures will only delay the introduction of the virus into a country if measures are implemented during the early phase. And we know that international restrictions cannot be sustained over a long period of time. Hence, the best preventive measure is to prevent the travel of symptomatic individuals. So this is the most efficient way to prevent transmission between passengers. So going back to our previous slide on breaking the chain. So again, COVID-19 or infectious agent, we want to interrupt that transmission, and we know that it has no definitive treatment yet. So basically, what we do is to limit the transmission of the virus. So what measures are the physical distancing, the respiratory hygiene, hand hygiene, environmental cleaning, and some of the public measures. So we want to stop the spread from respiratory droplets and hands. So what we usually do, physical distancing, hand hygiene, and medical mask. And we know that the mode of transmission is droplet, contact, and airborne. So we have to do our standard and transmission-based precautions, isolations of symptomatic, even those patients with exposure to COVID-19. We do some of the engineering controls that we've discussed. And we know that the portal of entry to other people are our mucous membranes. So it's very important that we do our safe IPC practices, the importance of the rational and appropriate PPE, and there's hand hygiene also. And again, no vaccine or prophylactic therapy yet. So we want to protect the susceptible hosts since, of course, we don't have these. So if we're going to break the chain for COVID-19 disease, we have to work on that. So I'd just like to show that in the Philippines, as of October 22, we have a total of around 400,000 cases. And the Philippines is one of the countries with a high COVID-19 risk. And this has been our cases so far since March of 2020. Although it might be a little, fortunately, we've been seeing a downtrend of our cases, and primarily owing to the following measures that were implemented since the start of the pandemic. And there are clinical trials that are being conducted in the United States and elsewhere to evaluate the safety and efficacy of pre and post exposure drug prophylaxis against COVID-19. So there's monoclonal antibodies that are being evaluated for post-exposure prophylaxis, and hydroxychloroquine as one of the candidate again agent for either pre or post-exposure prophylaxis. But available trial data is not effective in preventing infection. So far, no pharmaceutical intervention is known to be effective in preventing COVID-19. So a safe and effective vaccine for COVID-19 is well recognized as an additional tool to contribute to the control of the pandemic. But of course, the question is, where are we in the development of COVID-19 vaccines? So just to give you an introduction on vaccination, you know that vaccination is one of the great triumphs of medicine in dealing with infectious diseases. So it is a cost-effective measure in preventing infectious diseases, and it has saved millions of people worldwide. So vaccination eliminated smallpox, polio eliminated, measles eliminated in many countries, and according to the WHO, vaccination saves up to 3 million lives every year from severe infectious diseases. And immunization is a key component of primary health care, and this is undisputable human right. So since we are racing with time in developing an ideal vaccine for COVID-19, we need to take note of what an ideal vaccine should be. So the primary or major requirement should always be that the vaccine is safe to administer. That is your number one consideration, because you don't want any harm to your patient. And it should even be safe even in immunocompromised people. It should be highly effective and can induce sterilizing immunity, which can last for a long period of time. Secondarily, the vaccine should not be expensive so that everybody can have the chance to get the vaccine. We also want our vaccine to be easily administered. And of course, the best one is the oral route. But as we all know, most of the available vaccines is given as injectables. We also want our vaccine to have a high thermal stability so that even in tropical countries such as the Philippines or in any heated environment, the vaccine can maintain its potency. So we also want a vaccine that is of multivalent, the one that can actually cover as many serotypes or strains as possible. And of course, lastly, we also want our vaccine to have a long-lived immunity. However, there are many questions about how development of the vaccine should proceed and be fast-tracked. Building on the lessons learned from vaccine development with other coronavirus and from platform-based approach developed for other diseases. So some of the challenges is the possibility of enhanced diseases after vaccination. So examples of vaccine-induced enhancement of susceptibility to virus infection of aberrant pathogenesis have been documented, although the several mechanisms are still poorly understood. So this possibility might limit choices of vaccine types and increase the complexity of clinical trials. So we also know that we also try to check the evaluation of immune response to new vaccines because this has not yet been developed and standardized. Other challenges is the possibility of cross-reactivity of the vaccine to other coronaviruses and issues on vaccinating high-risk individuals. Examples are the pregnant women or the pediatric or the older individuals, especially those with comorbidities. So how soon will a vaccine be ready? So the vaccine development takes years. So all vaccines go through a rigorous process to make sure they are safe and effective. And the fastest vaccine that has ever been made was 5 years. So the clinical trial process is important because it explores if a candidate is safe and effective. So before a new product or vaccine can be tested to humans, the vaccine undergoes a preclinical phase. So these are that phase where the vaccine is tested on animals to see if there is an immune response. So this gives us an idea how the vaccine will behave on humans. Then after the after the preclinical phase, it undergoes the phases of clinical trials, which involves the human. So phase 1 usually involves a few people to assess its safety or whether they will develop certain adverse reactions, probably around 10 to 100 patients. Phase 2 is given to around 100 to 1,000 people to assess the safety and efficacy of the vaccine. Then on phase 3, given to a larger group, probably around 100,000, to confirm the efficacy and safety seen in phase 1 and phase 2. So, but in the case of COVID-19 vaccine development, scientists has jumped on it. So the years are compressed in months already. So the question is, when will we get the vaccine? So the COVID-19 pandemic is the most devastating one in the last 100 years after Spanish flu. And this mandates the speedy evaluation of multiple approaches for the development of the vaccine. So the goal now for COVID-19 vaccine is to develop it under 18 months. 18 months, and this would be the fastest that the scientists have created a new vaccine. And with the speed of vaccine development and all scientists working together, they are actually pretty much optimistic that they will be able to develop a vaccine by the end of 2020 or the early months of 2021. So there are several platforms for COVID-19 vaccine. DNA and RNA-based platforms are two new approaches for vaccine development, and they are among those with the greatest potential for speed. They can be made quickly because they require no culture or fermentation. Instead, they use a synthetic process. And this is followed by the recombinant subunit vaccines, replicating and non-replicating viral vector, and lastly, the two most common, the live attenuated and the inactivated vaccines. So this is from the World Health Organization. This is a draft landscape of the COVID-19 candidate vaccines as of October 19, 2020. So there are 44 candidate vaccines in clinical evaluation and around 154 candidate vaccines in preclinical evaluation. And majority of the vaccine candidates are protein-based, followed by viral vectors and the nucleic acid. So these are some of the things that the CDC wants us to know about vaccine planning. So first is that safety of COVID-19 vaccines is the top priority. So as we have mentioned earlier, the major requirement for a vaccine is that it is safe to be distributed to the population. And second, as we have mentioned, there are hundreds of candidate vaccines that are being developed and tested. So it is important that we keep in contact with all levels of government. And third, there may be limited supply of COVID-19 vaccine, but the goal is for everyone to be able to easily get a vaccine as soon as large quantities are available. Fourth is that there is a limited supply, and some groups may be recommended to get a COVID-19 vaccine first. But rest assured that experts are working on how to distribute these limited vaccines in a fair and ethical and transparent way. And of course, the pediatric population are part of special group of people that COVID-19 may not be recommended initially. So in the early trials of vaccine development, only non-pregnant adults participated. But as clinical trials continue to expand, the groups recommended to receive vaccines could change. And cost will not be an obstacle of getting vaccinated against COVID-19 because I'm sure every government is committed to providing free or low-cost COVID-19 vaccines. And lastly, COVID-19 vaccine is being updated as new information becomes available. So it's best that we keep our eyes open for new evidences and reports. So in the Philippines, currently, there are no clinical trials being done yet. So the Interagency Task Force Subtechnical Working Group on COVID-19 Vaccine Development, led by the DOST together with other government agencies, is gearing up for the conduct of COVID-19 vaccine phase 3 clinical trials in the country, which are set to begin coming this November. So all applications for clinical trials to be conducted in our country, not just here in our country, but every country, needs to be submitted to a special group of people to review the clinical trials. And usually they are composed of vaccine experts, technical experts, and scientists who will evaluate, identify, and recommend a possible vaccine candidate. And after thorough review of the clinical trial applications, this will be submitted to the FDA for final pass. And it may only begin upon the FDA's regulatory review and approval of the conduct of the clinical trials. So I guess this is my final slides. Thank you very much.
Thank you very much for the information and insightful presentations by Dr. Santos. And we are now moving to the second presentations, and the question and answer sessions will be conducted after the second lecture by Prof. Roslina. Let me share the screen of Prof. Roslina's CV. Prof. Roslina is a Prof. Roslina is a professor of medicine in the Deputy Dean of Undergraduate Studies in the National University of Malaysia, and she obtained her medical degree from Monash University, Melbourne, Australia, and subsequently trained in the internal medicine and obtained the MRCP in the UK and MMed in the UKM. She was honorary clinical research fellow at the Royal Hampshire Hospital and Northern General Hospital, Sheffield, where she also trained in respiratory medicine. Professor Roslina is a regular speaker at respiratory meetings and workshop, and also immediate past president of the Malaysian Thoracic Society, a position she held for 8 years. For Prof. Roslina, the stage is yours.
Okay, so thank you very much, Jeremy, for the kind introduction. Can you hear me?
Yes, I can.
Okay, so things clear. And just doing a quick tech check. So you can see me as well?
Yes,
that's great. Okay, thank you. So now comes the challenging part to share the screen. Okay, and I have my slides here. That's great. So can you see my slides?
Yes, I can see your slides
great.
now, but it's not on the full screen.
Okay, so yeah, I will just put it to full screen. Okay.
Okay.
So thank you very much, Jeremy. And I'd like to extend my thanks to AMSA International for inviting me to this webinar. And again, thank you especially to all of the participants who are here on a Sunday morning. I think I dare say that you have not wasted your time. That was an excellent first lecture that you heard, which Dr. Angelina presented, because essentially it covered really what we know about COVID. I mean, barring the basic virology, but it really gives you a snapshot right from the beginning, the early days, until now, where we are now, which is the vaccine development. And as you know, many countries are in their second or third wave, including my own, Malaysia. So as we speak, my country is facing a horrendous third wave, which is impacting the poorest state. And we heard about protecting the vulnerable because the outcomes are poorer. So yeah, so COVID is here to stay. And we need to think about how we're going to live with COVID, essentially. This is what I keep telling my fellow lecturers and my students. You know? Okay, so on to my topic today. My topic is going to take a bit of a different approach. You've heard about the public health aspects and about the scientific aspects, but my lecture is more conceptual, and it's meant to make you think a bit about where we are and what the future holds in terms of you all as learners, and that's the medical education part, and also as future healthcare providers, because probably you will be the biggest users of telemedicine and telehealth in years to come when you become practicing physicians. Okay, so the topic I've been given is telemedicine and virtual medical education. also known as digital learning, I suppose, and whether it's relevant. I mean, this topic is can I say it's a no-brainer? Of course, it's going to be relevant, even more so, increasingly. So this is where I work. We are in Kuala Lumpur, quite in the heart, actually. We're about 5 kilometers from the city center. And that's my office here. We have, yeah. So, we have a 800 bedded hospital. And during the first and the second waves, we were a COVID hospital. We were both taking COVID and non-COVID. So we were called what was called a hybrid COVID hospital, not 100%. Actually, in Malaysia, there's only one hospital, which is the infectious disease hospital, that is 100% COVID cases. So I hope that, those of you who are non-Malaysians, I understand that many of you attending today will one day drop by to our place and come and say hello to me. So what I'm going to be talking about is essentially initially the impact of COVID pandemic on healthcare and on learning, and a little bit about what is telemedicine and how it was used, and a bit about virtual medical education, and what happened during the pandemic. Actually, a lot of it about the impact, and maybe I will share some of my own personal insights. So as you've heard, the COVID-19 is a public health emergency of unprecedented scale. I say to my students, in a way, this is the event of a lifetime, and we are living in very exciting times. And, we need to rise to the challenge. We as healthcare providers, you as future healthcare providers, we need to together overcome this. And as you've heard, it takes an all of government and all of society approach. This is the one time where all government agencies and societies really have to come together. Otherwise, we're not going to win. So obviously ensuring the delivery of healthcare during this time is a very big challenge. I'm going to talk about the healthcare part first here, and the education part in the later half. So due to lockdowns, whether partial or total, we face that shortage of protective gear and hospital facilities. We had to be rearranged. There was a huge challenge to create COVID wards. And there was this risk of infection, and people at that time did not know how real the risk was, in fact, and how infective it could be to both patients and healthcare professionals. I was actually on call the day before we were officially a COVID hospital, and we had already the first 3 COVID cases, and 2 of them were intubated. So it was a huge, bang introduction to COVID that took all of us by surprise and left everyone scrambling to rearrange the provision of healthcare. And of course, it wasn't just the COVID patients, but the patients who had acute and chronic ailments, the elective surgeries, the diabetics, the pregnancy, the patients who had NCDs, chronic respiratory diseases, patients with heart disease, and they were actually at risk because all resources were focused on COVID, and we're still doing the catch up. There's still the backlog, and we've had patients who deteriorated during this time. And I think that this is a universal experience because they did not access healthcare, or they were too afraid, or because of lockdowns and because of fear of infection when they come to hospitals. So these are all very real for us. So we had to restructure how we deliver health and how we teach. And I'm sure for you all, how you all learn. Okay, so, and even for our trainees, it has impacted our trainees, meaning those who are in training for further postgraduate education, because resources had to be diverted from the university hospitals where they were training, and they had to go back to the Ministry of Health to fight the COVID cases. And this also disrupted their training. So there was quite a big impact. However, we've learned all about social distancing and physical distancing. and we've had to adopt new technologies so that life could continue. And people keep saying the new normal. And some people don't like to hear that because, well, for whatever reason, they think this makes it a bit unrealistic, when in fact this is going to, these things that we adopt, the ways of living, the ways of learning, the ways of delivering healthcare, change is the only constant in life. So I hope that what I'm going to say will perhaps give you some ideas, and maybe in your questions you can share even your experience in the chat. And I'm really interested to know as well how COVID impacted you all as students. So a bit about telemedicine. Telemedicine in the early days, they were sophisticated platforms and costly as well. But in the end, it was found that you can even do telemedicine with simple platforms such as WhatsApp and Telegram, right? So essentially, you just need the internet and you need a device that can connect to the internet. So things have really changed. I would say that in Malaysia, there are not many hospitals yet, in the public at least, that have embraced telemedicine. But I can say that even before the COVID pandemic, there were already initiatives. So there were some primary healthcare centers that had embraced this. And of interest, the Infectious Disease Hospital of Sungai Buloh has embraced telemedicine even before this for stable HIV cases. Right. So as I've said, it's essentially the use of electronic information and telecommunication technology to deliver healthcare in this pandemic while we practice social distancing. All you need is a phone and the internet. And why now? Because of obvious reasons: to decrease contact with the healthcare facilities and with other patients and with healthcare staff. So all this will help to reduce the risk of COVID-19 transmission. And we can evaluate, diagnose, and treat patients at a distance. Now, in this regard, I just mentioned that in Malaysia, the Malaysian Medical Council came up with a guideline. And in Malaysia, it is only meant to be used for existing patients who are stable. So meaning that new cases, they still have to come in and you have to still see them and assess them physically, because obviously the one thing that telemedicine can't do is for you to do a physical examination of the patient. A little bit about the history of telemedicine. It started in the 1950s, primarily in the United States. And it was initially via telephone, and they managed to actually send data in the form of images. And it was in Pennsylvania. It was reported the first 2 health centers were able to transmit radiology over the phone. And it was used mostly to connect doctors working with a patient in one location to specialists somewhere else, meaning that the smaller hospitals could access specialist expertise for consultation. So this was one of the early days of use. And it was very good for the rural and the hard to reach populations where specialists aren't readily available. And I think this is something that we need to think about. Can our countries, and I believe most of us in here in this forum are from low and middle income countries, and the internet, it's actually WHO or United Nations has said it is a human right. It is a basic human right to have access to internet, which means that internet isn't only just about knowledge, but it also can improve the quality of life by delivering healthcare, better access to healthcare. So really, we need to think about how we're going to reach out to these populations using telemedicine. And I think it starts with having a good infrastructure for the internet. And then throughout the next decades, there was equipment to conduct remote visits, and it was very expensive and complex. So it was slow, although it was growing. But with the internet and the smart devices that I'm sure all of you have access to now, and high quality video transmission, maybe largely driven by YouTube as a platform. But anyway, this is what we have today. And this enables us to deliver this at very much low cost. But just to say, it doesn't replace face-to-face consultation. So telemedicine actually complements rather than replaces our standard face-to-face consultation. Now, what's the difference between telemedicine and telehealth? So if I were to put it simply, let's say that telehealth embraces that Apple Watch that maybe you are wearing, okay, or some digital device. So people tend to use these two terms interchangeably, but there is a distinction. Telehealth is broader. It includes the technologies where you can provide patient care and improve the healthcare system delivery as a whole, and includes all these digital devices, monitoring devices, remote monitoring, for example, for the elderly parent that you can't, that you're not staying with, but you want to keep in touch with them. So this is telehealth, and it's broader. And telemedicine tends to refer to the remote clinical or distant clinical services. Telehealth, on the other hand, can be non-clinical, and it can provide training, administrative meetings, continuing medical education, and WHO has said it includes surveillance, health promotion, and public health functions. And I think many countries already have an app that helps to track COVID cases, contacts, and locations, and for you to log in wherever you go. So that's part of telehealth. All right, I think we've said that already. And it's telemedicine is useful for managing chronic conditions because particularly in my field, internal medicine, once they're stable, a lot of times what they want is you are there really just to provide them with that reassurance, to make sure they keep going, to make sure they comply with their medicines. And then the odd or occasional emergent problem, that they may bring up. But a lot of it, chronic conditions, is actually us as a healthcare provider partnering and understanding our patient and the challenges they face to manage their health. And in a way, telemedicine allows us to empower the patient better, right? Because they feel that, they feel that they don't actually have to go to the hospital. And that in itself, psychologically, is something, they feel that they have more control and more say. Right. So what else types of care apart from the chronic care can be delivered? You can screen patients for COVID. You can do recommendations for testing. You can guide them on isolation or quarantine, and general health care, which, chronic conditions, as I've said, and you can counsel them on nutrition. And I think in COVID, mental health counseling, you can provide support to our patients with reassurance and picking up if they are having mental health problems. Actually, this applies to students as well, and refer them appropriately. So it's been shown that the use of telemedicine as an alternative actually has benefits. I think somebody's mic is on. Okay, maybe you could mute your mic. Thank you. So the patients actually, it's convenient for them because they don't have to be away from work, particularly in the time of the pandemic. They might be working at home, and definitely they won't be in a traffic jam, right? They don't have to pay for parking, and they have less interference in the sense with their responsibilities towards the children or to looking after an elderly parent, and a lot of patients appreciate that. And then there's privacy. Because you will actually be one-to-one, and there's no bumping into somebody that you might know in the waiting room, for example, and there's no exposure to potentially contagious patients, and you can actually do prevention as well. So there's a lot of benefits to this, and I think this is only set to grow, and I foresee that in your practicing lifetime, you all are going to be very proficient in this. Right, what about the providers? Well, it is shown in some studies that actually increase revenue. I'm not very sure how that happens, and these are studies in the States, but apparently in private practice, you can actually earn more. I'm not sure whether this applies to the public hospitals, and there's improved management efficiency. And there are studies to show that there's improved health outcomes. So one telehealth program for patients with congestive heart failure, and this is a very common medical condition, it reduced the 30-day hospital admissions by 73% and 6 months readmission by 50%. And actually, I don't even think there's a drug that can do that. Yes, there are drugs that can prevent hospitalization and improve long-term outcome in heart failure. Yeah, but these studies are quite old. But as I recall, I don't think the magnitude of benefit was anywhere near 73% and 50%. So it's pretty amazing. And I think this is something that we need to embrace, and more research is needed. Okay, we've said about advice about non-emergency problems, and it's been shown that there are fewer missed appointment and cancellation. So that's wonderful, because when a patient drops out, and they miss an appointment for whatever reason, and then when they turn up, if they do turn up, firstly, it's hard to get another appointment. Okay, so the next appointment might be 6 months away. This is like I'm talking in my own hospital. And it's so hard to get a new appointment because they'll be passed around and around. So missed appointment is really a red flag, that the patient, you might lose the patient to follow up. So telemedicine is great in this way. And in fact, just by the by, that you can also perhaps now look to booking appointments online, which many private hospitals in Malaysia have done. But I think for my hospital, not yet. Okay, so that's a little bit, just a little bit about telemedicine in the COVID pandemic in a nutshell. And I'll move on now to virtual medical education and digital learning. So I'm sure, as you all know better than I, how COVID-19 has impacted your learning as students, right? It is unprecedented. And for us as teachers, as faculty, as academicians, it has dragged us kicking and screaming and reluctantly, into embracing digital education, virtual medical education, and all the technology that comes with it. Because as you know, this is nothing new. The platforms have been there for a long time. People have been talking about digital learning, about tele-education for a decade at least, but the take-up was slow. The embracing of these technologies was slow, and particularly it's said among the baby boomers, and I know you all are digital natives, millennials. No, you're not millennials, you're Gen Z, right? Some of you are Gen Z, so some of you are digital natives. So this is a whole cultural, psychological shift as well amongst the educators. But for now, because there is no choice, people have had to learn, like it or not. Otherwise, our students are not going to learn. So I always say that the COVID pandemic has been the best thing to happen to digital education, okay, to digital learning. In a kind of cynical kind of way, but it's true, right? It's the best catalyst that has occurred in recent years to push this forward. And the other impact has been notably for the preclinical students. Perhaps it doesn't matter as much because there was some face-to-face. For example, for us, the problem-based learning, the small group discussions, there was. But this can perhaps be ameliorated somewhat by having synchronous real-time interaction. But for meeting patients, this was a real challenge because many hospitals had limited the numbers of medical students or did not allow, especially if they were taking COVID cases. And the attendance at ward rounds, clinic, theaters, you name it, there have been limitations. And it has been a challenge to deliver clinical bedside teaching to the clinical students. And in fact, now speaking what's happening in Malaysia, just as we thought that, things were getting better and the students were coming back and they were back to the wards, a third wave happens. And we just really need to learn how we're going to live with risk and uncertainty, how we're going to negotiate, to navigate that. Because we can't keep the students away from the wards forever. You all are going to be part and parcel of the medical profession. We are going to be dealing, today it's COVID, tomorrow who knows. And we've just got to deal with that risk, appropriately and have measures how to mitigate risks. So this diagram is actually taken from a business model, and it talks about disruption and innovation. And as you know, crisis and opportunity, the Chinese character for crisis and opportunity is the same. So crisis is actually a time of opportunity. So anyway, in this model, there are three horizons, if you like. And this is us plodding along happily, and then a disruption occurs and things go downhill. This is one. However, in another scenario, another horizon, where you are plodding along, or we, you know, as in the healthcare profession and education, and perhaps we weren't doing so great as another place, another country, but within that, you had these pockets of the future that were present, meaning you had some of the technologies, you had some of the people who were interested in telemedicine, for example. So you had some, so your country maybe had good internet access. So these are what we call pockets of the future. So from this, now, as you build up, now you have disruption, you are able to overcome with research and with innovation, you know, and over time, of course, this will naturally decline. And here is another model where you have pockets of the future now, pockets of the future with you in your ecosystem, and you proceed to go on. And even if with another disruption, you can still thrive. So actually what we need to be looking at, I know people talking about surviving 2020, but we need to move from a survival mindset to a thriving mindset. Because if you just think about surviving, maybe this is what is going to happen. But we need to have that resilience and that growth and the thriving mindset, no matter the challenge. And of course, this is easier said than done. But facing disruption brought by COVID pandemic, it all starts with the mind. And this is what I want to emphasize to you students, yeah? That it is, you guys are young, you guys can probably adapt to change better than older people. So I guess the future of health and the future of education is to a large extent in your hands, right? Because one thing that you have and I don't have is that you have a bigger say in the future just because of your youth. And I think that's a gift that you all must not squander. Okay, so sorry to wax philosophical, but for us as faculty and providers of education, balancing student safety and clinical care for patients is really a juggling act, you know. So and a lot of it comes down to having good SOP. I don't know what you call it in your country. In Malaysia, it's called SOPs, and we have had so many SOPs or standard operational procedures come out since COVID, be it for the public, be it for education, be it for patients, you know, be it for the hospital. And this is what is known as risk mitigation. And risk is something, and uncertainty is something that is necessary for the human condition, meaning we always live with risk. And the risk of COVID, it's just a matter of greater or lesser risk, but we need to acknowledge that that risk is always going to be there. I keep telling my students and my faculty that it's never going to be zero. You know, it's never going to be no COVID versus, you know, 100% safety, never. Even in real life, even pre-COVID, we are never risk-free. So it starts with acknowledging the risk, having a real understanding what the risk is for this particular patient, for this particular student, for this particular situation, and having ways to mitigate. So I think coming to understand the reality of what we're facing, understanding that is the starting point for risk mitigation. And we know that medical students report feelings of uncertainty and anxiety about their personal safety and about learning. And just as an aside, mental health problems, and this is not just in Malaysia, but it is a phenomenon worldwide in every university, in every, you know, it's not a cultural thing just to say that it's in one country, but it's global, that the young people of today, for whatever reason, face more mental health issues, or it's better picked up maybe, but I don't think so. I think they really do face more mental health issues than generations of medical students before them. And I'm seeing this firsthand. And to say that this is an understatement, because during the time when we were all locked down at homes, students were isolated. They did not have their peers. Some of them, their parents also lost jobs. So there was a income, threat to income. And there were many, many challenging things. I'm sure some of you can identify with this. And that on top of having to adapt to a new learning and uncertainty. So, and like, when is our exams? When are we ever going to graduate? So for me, in reality, that really meant rescheduling everything, and the final year exams. And in fact, because we didn't know when the students were going to come back, when they were going to be in the wards, when they were going to be able to see, it was just so uncertain. And we had to actually change our scheduling at least 4 times, between March to July. So can you imagine? But these were some of the things that we had to do to adapt. One of the things that's very important, and I think I would commend my medical student body about this, the effective communication. The students would keep asking me, and they were always one step ahead. And I realized that in a way that the medical school could not fail them in the sense of frequent communication, reassurance, be it by text messages, by infographics, by circulars. And of course, the old way of doing things was by circular and emailing to the students. Now, how many of you all open your email? I wonder, so new ways of communication, like having WhatsApp, messaging, and so on, that helped. But I have to say, the students were always one step ahead of me. They would always be asking something which I hadn't thought of. Then I have to answer. But in a sense, for me, administratively, it was very difficult to communicate to students that messaging, crisis messaging during this time, actually any medical school is constrained by the university, and then subsequently by the Ministry of Education, and then before that by the Security Council or the government or the authority for SOPs and for messaging. So these things take time. And one of the challenges was to tell the students that, yes, the guidelines will come, but I can't create my own guidelines and set the regulations without the blessing of the university and without the blessing of the Ministry of Education, so that everything is in line, because we have to kind of be doing things in the same way. Although for medical school, yes, it's a bit different in the sense of we have the hospital and the clinical teaching, which other faculties didn't. So, so I think the take-home message is that in times of crisis, communication, early, prompt, and relevant, and engagement is key. And you have to use whatever platforms are available to you for communication. So what some medical schools did was create task force and engage the students. I can't say that we actually did this, but we did have meetings with student representatives. But short of creating a task force, we had a task force for other things, but the students weren't represented. We had other venues where students were represented. But this is one way that some medical schools did. They actually created a task force. And I think that we need to learn to take students as ambassadors and as future peers. And I know that I don't know about you all in your medical schools, but maybe in Asia, the mindset of the teacher and the student is very fixed, and that maintaining that distance is imperative. And that one thing that has changed my perspective from being just a clinician who expects the students to know their cases very well to becoming the administrative deputy dean in charge of education is that I have been able to see another side of students, which I previously did not. And it's things like organizing this webinar today, seeing you guys as, not just students, but professionals, future healthcare professionals who can take care of your own kind. So this is wonderful. And I think that there needs to be a change in mindset of medical schools, administration, to embrace the voice of the students better, to be more open, and to listen to the students, because I think students and young people have a lot to offer. Right, so you need to be champions for change, and and slowly chip away at that obstacle where your voice will be better heard, and you will create a better learning environment for everybody, and better teaching environment for the teachers as well. Okay, so I think many medical schools also have mentors aside of your academic supervisors. So the mentors, we sensitize them to the possibility of mental health issues. Sorry for the spelling, because of isolation and uncertainty. So during this time also, there are many, many publications. I think in terms of COVID publications, the science of it took off exponentially. We saw this at a rate that had never been seen before. And a lot of resources, a lot of journals allowed access, that whereas before you had to pay, but during COVID pandemic, a lot of things were free, including education resources for students. So in terms of medical education, there were a lot of publications, right? A lot of things about the impact. So I don't know if this is real, because the students here at home, they all look calm and well-dressed and look very well adapted. But I think in reality, it was very different, and everybody adapted differently. And sometimes they don't even want to put their video on, because maybe they, they're at home, so chill. So it's not like as if they're coming to class. So yeah, I'm not sure how representative this is. I'm sure you can relate with that. Okay, so so a lot of things had to go online, like case-based learning, lectures, discussion groups, and telling lecturers that just putting your PowerPoint online doesn't constitute digital learning, which we had to try to introduce flipped classroom to the lecturers, where there's pre-reading and then there's active engagement, how to make your lectures more engaging, right? Not just giving the students your PowerPoint, right? So and then we had to train our lecturers how to use platforms such as Zoom or Microsoft Teams, or Moodle. And I'm sure this is all over. The more I read the papers, it seemed that there were more similarities between medical schools, no matter where you were, whether you were in a low-income country or in a high-income country. The challenges in terms of adaptation of medical schools was the same. So we could use YouTube, mobile apps, whatever that we had. And we recognize that, yes, probably the quality isn't the best at the moment, but I'm sure all medical schools are committed to improving, so that we learn and you learn. So we are both learning together, and we value the student feedback and suggestions. And in some schools, there have been some adaptation to learning, where the students have been engaged in public health activities that may not involve physical patient contact. So some students have been roped in by the medical or the public health departments to help with contact tracing of their cases, staffing the hotline, training them how to give advice to concerned callers. So this has been really very good, I think, because then students build their commitment to social responsibility apart from learning public health. So I always say to my public health colleagues that, last time the students thought public health was very boring, but I think now, even the lecturers included, public health has become really sexy, because you can see so many aspects. And, where would we be without the public health measures to contain this COVID pandemic? So it has really opened the eyes of many people. Public health and global health have become extremely attractive. Right, so moving on, that was a little bit about the teaching and learning adaptation. So what about assessment? So early on in the pandemic, and this was in 13th of March actually, we learned that, premier medical schools such as Cambridge said, okay, students, no final year exams for you, you're graduating early and you're entering the NHS. So, and how did this happen? And actually a lot of it was because they had good programmatic assessment, meaning there was a lot of continuous assessment, and they were confident that the students didn't need clinical exams. They had their theory exams. Of course, GMC was very concerned because the professional bodies, regulatory bodies, want to ensure that the learning outcomes have been met. So I think there was a bit of a tussle, but in the end, I believe Cambridge got their way, and the students actually graduated without doing clinical exams. So this is something for us to think about. How do we conduct assessment? Can we improve it so that there is less reliance on final graduating exams, and to improve the assessment along the way? And I think the answer to that is obviously yes. So we had to defer workplace-based assessments, such as your mini clinical mini clinical assessments, mini SCACs, and of course we had to do online multiple choice. So, but these are only temporary, because we really don't really know what's the future holds. And there could be lockdowns again, and education institutions could be closed again. One of the things that emerged during this time was the emergence of talented champions among our teaching staff. There were people who were actually avid learners of technology and who avidly adapted. So what we did was we identified these people, and these people were the ones to teach their peers. And it's been amazing. We've seen, and I have to say, they were mainly the younger lecturers who were able to become mentors and advisors and guides during this time, because they adapted very fast to the learning platforms, and they were able to master it and to teach us how to use. So the expertise became an issue, but along the way we discovered champions, in-house, on-the-job experts. All right, and of course supporting, and we had to conduct workshops and all this. I had a sense of deja vu with this third wave, because suddenly there were so many webinar invitations, which reminded me of what happened in March, because in March suddenly there were so many webinars going on like this. Okay. Right, so what about selection of students? So with this pandemic, should we be thinking about how we select our students? Should we select students who show resilience, who can overcome this, who have mental toughness, who have strategic thinking, who are able to solve problems, and with a certain acceptance of uncertainty? Should we be looking apart from academic, cognitive ability, the ability of our students to respond to unexpected events? And I put there kindness and compassion, because this is a time that calls for kindness and compassion, not only to our patients and to our students and to our peers, but also to ourselves, because we need that to survive, and we need that to thrive. So there may be other ways of how we want to select our students, thinking of the challenges of the future. And what about the medical school of the future? Of course, it's got to use a lot of technology, online learning, virtual patients, teleconsultations. So do we need to train our students how to do teleconsultations and telemedicine? I think the answer is yes. We need to train future medical students to be comfortable and to be able to do this in their careers, in their practicing careers. And of course, we have had a lot of reliance on simulation labs with the use of mannequins and other equipment to propel learning during this time, where students, to reduce contact with real life patients. And in terms of simulation, there's basic skills lab, and then there's the advanced that relies more on virtual learning or hybrid of augmented reality. So the other thing that we would want to think about is competency-based education. So as you know now, medical schools and medical programs, with few exceptions, have timelines. So you have first year, second year, or phase 1, phase 2, phase 3. Now, competency-based education does not rely on time. It relies on the ability of the learner to prove their competence. So meaning that instead of finishing in 5 years, you might be able to finish in 4 years. Or if you're a little bit slower, maybe you finish in 6 years. But there isn't a defined timeline. It's as long as everything you can complete at your own pace. But probably in reality, there has to be some certain time limit as well to be realistic, right? So for example, let's say CPR, cardiopulmonary resuscitation, you have a CPR mannequin in your basic skills lab. So the students can go there and practice. There will be a guide, not in person, but a video guide, how to do it. And perhaps if you request, you can have one face-to-face session to see whether you're ready. And the student will record their performance of CPR and send it to their supervisor, and the supervisor will look at it and say, oh yeah, you're ready or you're not ready to be assessed. So this does not meet any time frame, right? You do it in your own time, and when you think, instead of having an exam at a particular time point, you say, okay, your supervisor says, all right, you're ready to be assessed, and we can meet face to face and do your assessment. So this is just one example. And I think as far as medical schools and medical programs, I believe that Canada now has got at least one competency-based medical program. So what sorts of competencies? It can be technical or functional. For example, sorry, another spelling there. So a knowledge, attitude, and skills, such as, related to procedures. And it can also be to do with attitudes and skills to plan, to mobilize, and to organize, such as what you guys are demonstrating today. And better programmatic assessment, continuous assessment that is embedded throughout, online assessments, open book. And what about online OSCEs? Can OSCEs be done online? It has been done in Singapore, actually, but a lot of it was actually through having adequate recording of the performance. And in fact, the performance was actually live. The student actually still had to come in, but to reduce the contact, the assessment was done by transmission. Yeah? I just want to say again that face-to-face teaching, because we are not dealing with virtual patients, we're dealing with real lives and real patients. We work in real hospitals. So these are only a supplement, it can never replace. And that human touch, although perhaps you could do it online, but really to be human is to have real contact, and that's part of our humanity, which can never be replaced by technology. So in conclusion, while it's important that we need to act quickly when making adaptations, for us as educators and medical schools, it's important to think in the longer term. What longer term shifts and adaptations to embrace as the new normal for virtual medical education. And these adaptations were driven by urgency and emergency, but we need to think of a more stable state way, in a more stable state way now of providing this and how to sustain these adaptations. So I'd like just to thank you for listening. I welcome your ideas and how we can collectively improve this experience of learning and of delivering healthcare for our patients and for our students. And last but not least, stay safe. So thank you very much.
Thank you very much, Prof. Roslina, for sharing the informative and reflective lectures about the future of the medical educations and teleconsultations on this pandemic era. And we are going for the question and answer session. So I have compiled the questions from all the participants, and I will get them in order. So I will get for Dr. Santos first. The first three questions for Dr. Santos. The first one is from Muhammad Syed Boska in Bangladesh. Will the current and future frequent evaluations of this new virus can be a red flag for the efficacy of the candidate vaccine that is now ongoing for trials?
Okay, actually, yes, this is definitely a red flag because we know that viruses are very good at mutating. So, because by the time that we have developed our first COVID-19 vaccine, we might be faced with a new strain of virus, which is not very effective with the vaccine that we have developed. That's why during this time, it's very important that we limit the spread of the virus so that, because the higher the chances that they are limited, the higher the risk that they will mutate. So IPC measures are very important.
Okay, thank you very much. We move to the second questions. Does COVID-19 positive patients with mild symptoms and normal blood investigation results likely to not develop any antibody against the virus the same way as any asymptomatic patients?
Well, however, up to now, I think it's very unclear whether there is really a difference in the antibody response found in individuals with severe, mild, or in patients who are asymptomatic, because most of the studies that they've done are patients who are hospitalized So it remains unclear what degree and duration of immunity that antibodies confer with these patients.
Okay, thank you very much. And we move to the third questions. In aerosol generating procedures like upper GI endoscopy, not done in a negative pressure room, what complete precautions should healthcare workers need in these situations?
So this is an aerosol generating procedure. So as we have mentioned, it's very important that you have an airborne droplet and contact precaution. So we usually term this as a level 4 PPE. So this usually involves the use of your coveralls, the gowns, a respirator, a face shield or goggles, and use of double gloves. So the complete gear for a level 4 PPE should be used in these situations.
Okay, thank you very much, Dr. Santos. And we are moving to the first three questions for Prof. Roslina. It's by Keisha from Indonesia. By executing telehealth medicine, there must be limitations compared to direct contact with the patients. What are the main challenges and how to overcome?
Right. So thank you for this question, Keisha. Yes, of course, there are limitations, and the primary one would be physical examination because you're remote. As I said, it is in most telehealth or telemedicine services, the patient isn't permanently forever remote, meaning that probably in 1 year, there are scheduled appointments for the patient to come in to be seen physically. So that's one way of overcoming it. But of course, when you set up the service, there must be a way, if the patient has any problem that you cannot solve remotely, that the patient is able to quickly and easily be seen by the healthcare provider, be it through emergency or by having slots in your appointment book for patients who are at remote, who are being managed remotely, to come in as walk-in cases. And most clinics actually do have slots for walk-in cases. So I think other limitations, I mean, you could divide them into technological and non-technological. So that was a non-technological, but I think one of the limitations in reality is the quality of the internet, whether the patient has internet access and whether the patient is comfortable with technology. So this, I think, would be the biggest two challenges. Would that be okay? Sort of answered it?
Okay, thank you very much, Prof. Roslina. We are moving to the second question. What are your thoughts on how medical education should continue with students attending clinical postings in hospitals and theory classes with standard prevention control by Karthik from India?
Yes, thank you for the question, Karthik. My stand is that medical education must continue. And a lot of my role has been to reassure my peers and to accept, well, you think about it, what's the alternative reality? COVID is going to be with us for a while, we don't know, maybe another 2 years. Are we going to keep deferring our clinical teaching? Are we going to keep deferring our exams until when? Obviously, this is an unsustainable position to take. So therefore, the teaching and the assessment and the learning has to go on. But the question is, how do you make it safe? And as I've said, it's never going to be 100% safe. So what kind of risk can you tolerate? You know, what kind of risk can your patients, your students tolerate? And your staff. I think this is the biggest challenge. And then obviously there have to be measures to mitigate this. For example, in my own place, now in any one ward, only 5 students can be there. And they have to have appropriate PPE. And for clinics, only 1 student in 1 room at a time. Everything subject to physical distancing. So if physical distancing cannot be maintained, then it has to be relooked. So my thoughts are that life must go on and we have to adapt in the best possible way how to protect our students, our patients, and our faculty at the same time. And we are guided by existing protocols from public health experts and these are made into SOP by the authorities, and we follow that. So when we wanted the students to come back, we actually work with our hospital. So faculty and hospital work together to say what would be advice, what is feasible, what is doable, whereby we can still manage our students and let them still learn and yet be safe and protect them to a reasonable extent from risks. So I know this is like very airy-fairy, but these are the principles that we hold to. So what's happened in reality is that, yes, but as time goes by, and this is human behavior, soon the numbers were disregarded, particularly when things became better, you know. So although the SOPs were still in place, people tended not to regard them. And numbers of students in the wards went up. People were less, I'm talking about people, not just the students, even the specialists were less careful about the physical distancing and about wearing masks all the time. So like masks would be on the chin or wherever. People get complacent and people get too familiar. And I think this is a challenge everywhere, not just within the learning or within the hospital environment.
Thank you.
Yeah.
Thank you very much, Prof. Roslina. And we move to the third questions from Sayat Boska in Bangladesh. What are the recommendations to initiate telemedicine services in poor rural communities?
Thank you for raising this. I think these are the vulnerable and the underserved. And actually, it's just, if I could just answer this simply, it starts with good internet access, right? So the first thing is the government has to provide adequate infrastructure in terms of internet access before we can even think about delivering telemedicine. So as I've said, internet access is a basic human right. And this is what must be pushed for. I don't know, I mean, this is about education. During the pandemic, I think the Malaysian students know, one girl became very famous. She was actually she was a pre-university student in a foundation program of a university in East Malaysia, and that country, which is now facing the brunt of the pandemic, was the poorest state in Malaysia. And she had online exams, and she was so determined to have her exams that she went into a place where she could have good signal, and she actually climbed a tree and made a place for herself, a platform where she could receive signal and she could do her exam. And she just went viral, you know. And of course there was some political kickback after that. But anyway, suffice to say that she illustrated really that the internet has to be provided first so that people in rural areas can access health and education. It's a human right.
Okay, thank you very much, Prof. Roslina, for answering the questions. We are now moving to the vaccine questions. The first three questions is from Lawilius in Indonesia. Will emergency use of vaccine is justified in this COVID-19 pandemic, as some countries are ready for vaccination program in the end of this year?
Yes, actually, there are the use of emergency. The use of emergency for vaccine can be justified during this time. There are other countries the vaccines are being given already. So yes, it can be justified during this time.
Thank you very much for the answer.
Okay.
And we move to the second questions. When vaccines are developed within such a short interval, is it actually possible to assure 100% safety in terms of long-term complications?
Actually, it's very hard to assure 100% safety of the vaccines. Actually, there's really no vaccine that is 100% safe. But I guarantee you that all the governments or all the experts are making sure that the vaccines that are being developed are at least it can have an immune response that we are expecting.
Okay, thank you very much. We move to the third questions. From Hasna in Indonesia, can the vaccine prevent the infections of COVID-19 forever, or there is a limited time? And should we take the vaccination regularly, or it's enough to take it once only? Thank you very much.
Okay, so it's really hard to say right now that the vaccines that we are developing can be given once, because most of the vaccines that we have actually, if I will to compare it to the available vaccines that we have right now, most of the vaccines that we have, they usually have more than one doses. So, but eyeballing the list of the vaccines, candidate vaccines that are being developed right now, most of the vaccines that are being developed have more than one doses. So of course, we want a vaccine that can be given once only, but right now that's very hard, especially that we don't have any measures or assays that could standardize the immune response of these vaccines. So yeah, hopefully the vaccines that can be developed would be just a one shot only. So that would be very convenient to everybody.
Thank you very much. We are moving to the next panel of questions to Prof. Roslina. From Shreya Manyar in India, it is believed that even the slightest soft touch on behalf of the doctors cures the most of the patients, involving the later emotional content. So, will telemedicine compensate for that, and how?
Okay, thanks, Shreya. This is a very interesting question. I think you would agree with me, or well, you guys are not practicing yet, but I will say this, that when a doctor treats a patient, you are not just prescribing medicine, but you are actually prescribing a piece of yourself. Because that piece of yourself, it has to be a very, very good piece. So you need to develop those things, those traits like compassion, empathy, kindness, being able to solve problems, all that. So the question is, how do you prescribe yourself when you are remote and you're not face to face with your patient, right? So it's like, how do I prescribe a piece of myself to you guys today also, because you guys are remote. So there's this thing called immediacy in tele-learning or in distant learning. And these immediacy behaviors, yeah, that's the term, immediacy behaviors are things that allow you to better relate and to engage with your learners or with your audience, but particularly so with learners. And I think it can be said to be the same with patients. So these things are actually not new. A lot of it is body language. So a lot of it is your tone, your eye contact, knowing your students by name or your patient, addressing them by name, trying to show a real interest in them as a human being as well. So I think that while it can never replace the, let me put it another way. You could be face to face with your patient, but if you were physically together with your patient, but you don't have the skill of empathy and listening and understanding, it still doesn't work, right? If you don't have that ability, what I just say is like to prescribe a piece of yourself, even though you're face to face, somebody else who is remote, but with these immediacy behaviors will have more success doing it. So it's not just the technology, yes, but as with many things, a lot of it in the end eventually boils down to human behavior. So I think that you could be face to face and still not be able to comfort your patient. And you could be at a distance and still be able to achieve that engagement and to touch them in their hearts and emotionally. So I think that's how we should think about it.
Okay, thank you very much, Prof. Roslina. And we move to the next question from Ashi in India. What could be the possible course of actions for treatment of patients with exaggerating symptoms living in remote areas?
Yes, this is a difficult question because there's so many aspects. It is like when you're doing telemedicine, as opposed to if there's no telemedicine and this patient has severe symptoms and they still need to come in. So there, the added value of having some form of communication, you know, you can't treat the underlying cause, you can't treat that disease, but you could make a better accurate assessment, and you could reassure the patient whether they need to come in or not need to come in. And if they need to come in, you know, you could listen to how, when they're going to come in. You could arrange for them to be received at the nearest hospital. So you could facilitate that, even though you couldn't treat them from remote. But what I'm saying is that this scenario where a patient who is living in a remote area and having an urgent problem that needs to be addressed could happen whether you have telemedicine or whether you don't have telemedicine. You understand what I'm saying, yeah? So in that case, it is better to have the telemedicine, even though you can't actually treat them then and there, but you could do a lot in terms of relieving the anxiety, making plans for them to come in, and facilitating their contact with, eventually, with the healthcare personnel or the center. So yeah, so I don't see any disadvantages there. I can only see advantages of having that for patients living in remote areas. I mean, it's better to have it than not to have, even though you can't treat them immediately, because they still need to come in.
Okay, thank you very much. We are moving to the next questions. What are the recommendations for adapting our room environment ideal for the virtual education?
Wow, if only had a wish list, huh? Okay, I presume this, our room is your room at home or your room in the hostel, I'm presuming. Um, so I suppose the answer is different for every student, for every individual. But of course, the lack of distraction. I mean, even from people who are working from home, we've seen all these video clips that are hilarious. You know, they're trying to work or they're trying to study, and then the child runs in or whatever. So yeah, so the lack of distraction, I think that's a primarily thing. It is not always achievable. That's why I say it depends on your circumstances, because you might be living in a household where there's many in the household. You might not be able to achieve that privacy and that lack of distraction. So ideally, you know, a quiet environment where there's no distraction, good internet access, you're comfortable, you can access, you can get away for short periods to have your breaks. So access to food and so on is very important, because nobody can sit online for 8 hours. Okay, so I'm very pleased to see that your webinars were only like 2 hours a day, which is the way to go, because in this era I see people organizing webinars for afternoon and morning. Just, you know, the concentration is not there. So of course the technology as well, the internet access, I really can't think of very much. I think that's you probably have better ideas than me, but I'd say it boils down to your individual circumstances, what you can afford, what, without alienating the rest of your family members. And in terms of the medical school, what we did was we actually did a walkabout of all the rooms where the students would be learning, and then we put like marks for where they would sit, how far apart they had to sit, and whether the small group discussion rooms, how many people they could accommodate. Fortunately, we had a small group size of 8. So our rooms could actually adopt 8 people, you know, with the lecturer. So maintaining 1 meter, we use 1 meter distance. So that's it on the practical terms. I probably haven't answered very well.
Thank you very much, Prof. Roslina. Thank you for the comprehensive answers. And we are at the end of this question and answer sessions. Thank you for your enthusiasm to ask the questions. However, we are apologize for many questions left unanswered. I hope that we have enough time in the future to answer these questions. And I would like to remind the participants to open the camera because we are getting to the photo sessions after this. We would like to thank you all the participants and all the speakers from Dr. Roslina and Dr. Santos and Dr. Gurmit and Dr. Gurbilas for yesterday's sessions, for sharing very insightful information about COVID. and its prevention, management, and approach. And I would like to thank you all participants for showing your enthusiasm during the sessions. And once more, I want to appreciate the speakers by giving the certificate, and we will have the photo session with the certificate. The first one is for Prof. Roslina, and I will take a photo with Prof. Roslina right now in 1, 2, and 3. Thank you very much, Prof. Roslina, for joining us and give the insightful informations. And the second one is for Dr. Angeline. I will take the photos for Dr. Angeline with the certificates in 1, 2, and 3. Thank you very much, Dr. Santos, for joining us and sharing the very insightful informations. And I would like to recapitulate what we get today from the lectures. The COVID preventions is about breaking the chain for COVID-19 disease. And it could be done with discipline from the contact, droplet, and airborne precautions. And we can do that from the primary measures into the secondary measures. The primary measures is the individual measures such as physical distancing, respiratory hygiene, and hand hygiene. And for the populations, we can do the limiting close physical or making the interpersonal measure. And for the secondary measures, we can make sure that the population is aware of the prevention of this pandemic. And as long as we do the primary and secondary prevention, I hope that this pandemic can be controlled. And for the vaccine progress, we are entering the phase 3 of the progress. With the phase 1 is the safety and dosage measuring, and the stage 2 is the small group examinations, and the stage 3 is the large group examination, and it's expected to complete within 18 months. However, there are some measures taken to express the progression of this vaccine's development. And for the telemedicine, we know now that the telemedicine is a promising aspect because of its convenience and adherence. However, it needs a good internet connections. Therefore, there is need for the governmental actions to provide internet as the basic needs for everybody. And COVID-19 has bring various adaptations to our life, mostly in the medical learning and medical services. However, we must adapt and we must overcome this pandemic with this medical learning and medical services with the adaptations. With all of these measures, like the prevention, like the management, and the adaptations of COVID-19, I believe that we all will get the best measures and best outcomes through this pandemic. Through this negativity, we can make some positivity out of it. That's all for today's lectures. I would like to thank the speaker and participant again. And I would say thank you very much for joining us. And we are going to take a short photo sessions for the participants. I would like to ask the participants to open their camera. We are going to take photos together. Okay, I would like to take the first slide in 1, 2, and 3. I will take the second slide. Please stay in 1, 2, and 3. I will take the third slide, please. Please stay in 1, 2, and 3. The fourth slide in 1, 2, and 3. In fifth slide in 1, 2, and 3. And I would like to thank you. The photo session is done, and would like to remind all the participants to fill the to fill the post-test of this COVID webinar, because you will get the certificates once you fill the pre-test and the post-test, and you get the minimum post-test score of 60%. So you must fill the post-test, and there is a feedback form. Please send what you want to expect from us in the next webinar, so we can improve and we can be better for the next webinar. That's all for today. I hope everyone stay healthy and stay happy. Thank you very much and enjoy your weekend.